Good morning to all distinguished guests and to all participants. Welcome to the Tri Mandiri Sakti Institute of Health Sciences Bengkulu for the 4th International Nursing Conference on Response in the COVID-19 Disaster 2021. My name is Muhammad Adnan Effendi Putra, and it is a great honor for me to welcome you in this event, where we will share and exchange information, experiences, and researchers in all aspects of response to COVID-19 as a disaster from the healthcare point of view. Before we start the program today, we would like to welcome with honor the Director of the Tri Mandiri Sakti Institute of Health Sciences, Bapak Dr. Andes Haji SFNDMS, the Chairman, Representative from LL-Dikti Wilayah to Palembang, or the Higher Education Service Institute Region 2, Palembang, Bapak, Ibu. Professor Celeste Aure di Makulangan, RN, Man, PhD, from the Department of Nursing of the Philippine Women's University. Nurse Nuraini Agustini, BN, MSc, PhD, from the School of Nursing, Faculty of Health Sciences, Syarif Hidayatullah State Islamic University, Jakarta. And Nurse Pawiliyah, S.Kep, Man, as the Dean of Nursing Program of the Tri Mandiri Sakti Institute of Health Sciences, Bengkulu. Sir Tito Abordo, from the King's College Hospital NHS Foundation, Trust, Denmark Hill, London. Dean of Midwifery Program, Dean of Public Health Program, and to all the distinguished guests and participants. My sincere apologies for there may be mistakes in delivering the names in the titles. Before we proceed to officially start the event, please allow me to show you a little background about the Bengkulu propers, the welcoming dance from Bengkulu, and the Tri Mandiri Sakti Institute of Health Sciences campus profile. Hello everyone, welcome to the 4th International Nursing Conference on Response to the COVID-19 Disaster, hosted by the Tri Mandiri Sakti Institute of Health Sciences Bengkulu. We have brought to you our beloved speakers, Sir Tito Abordo, as an experienced practitioner based in London. He is a senior staff at the Emergency Department of the King's College Hospital, NHS Foundation, Trust, Denmark Hill, London. Ladies and gentlemen, Sir Tito Abordo. Following next is Ma'am Celeste Aure, RN, Man, PhD. She is an adjunct professor at the Philippine Women's University, Manila, Philippines. Ladies and gentlemen, Ma'am Celeste Aure. Next, brought to us is Nurse Nuraini Agustini, BN, MSc, PhD, from the School of Nursing, Faculty of Health Sciences, Syarif Hidayatullah State Islamic University, Jakarta, Indonesia. Ladies and gentlemen, Nurse Nuraini Agustini. Our last is our very own teacher, Nurse Pawiliyah, S.Kep, Man, Dean of Nursing Program of the Tri Mandiri Sakti Institute of Health Sciences, Bengkulu, Indonesia. Ladies and gentlemen, this is Tari Persembahan.
Kota ini adalah peluang,
Bengkulu City is
di
an
mana doa
opportunity
dan harapan menjadi kenyataan.
where hopes become reality.
Bengkulu adalah kota
Bengkulu is a
pelayanan,
city of good
di
service,
mana pemerintah
where its government is highly committed to its people's welfare.
memberikan layanan publik
By giving public services with heart,
pada peningkatan
puts focus to enhancing public service for social welfare.
kota ini.
In this city, health is priority,
menjadi harapan
becoming the hope and prayers of each of its residents,
mewujudkan pemerintahan
emphasizing the religious and happy government in the city's mission.
sehingga masyarakatnya
In order to build a generation of residents who are smart, happy, and with good morals. Ladies and gentlemen, the three Mandiri Sakti Bengkulu profile.
Pendidikan merupakan gudang ilmu pengetahuan masa depan. Sehingga STIKES Mandiri Sakti Bengkulu komitmen menciptakan lulusan yang berkualitas, yang memiliki kompetensi dan mampu bersaing di dunia kerja. Sebagai perguruan tinggi ilmu kesehatan pertama dan terbaik di Provinsi Bengkulu, STIKES Mandiri Sakti Bengkulu telah terakreditasi secara nasional oleh Badan Akreditasi Nasional (BAN PT) dan oleh Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan (LAMPTKES). Semua program studi sudah terakreditasi B.
STIKES Mandiri Sakti Bengkulu menyelenggarakan pendidikan sarjana, S1 Keperawatan, Profesi Nurse, S1 Kesehatan Masyarakat, D3 Kebidanan, Sarjana Terapan Kebidanan, Profesi Kebidanan. STIKES juga membuka kelas khusus karyawan, alih jenjang D3 Kebidanan ke Sarjana Terapan Kebidanan, S1 D4 Keperawatan ke Profesi Nurse, D3 Keperawatan ke S1 Keperawatan Nurse, D4 Kebidanan, S1 Kebidanan ke Profesi Bidan, D3 Kesehatan ke S1 Kesehatan Masyarakat. Untuk mendukung kelancaran proses studi mahasiswa, STIKES Mandiri Sakti memiliki fasilitas yang lengkap dan modern. Raih beasiswa dan penempatan kerja di dalam dan luar negeri. Pastikan Anda kuliah di STIKES Mandiri Sakti Bengkulu dan dapatkan beasiswa langsung dan masuk tanpa tes serta gratis uang pendaftaran. 100 pendaftar pertama, siswa berprestasi peringkat 1 hingga 10 di sekolah, siswa berprestasi olahraga seni dan lainnya. Kampus STIKES TMS Jalan Hibrida nomor 03 Kota Bengkulu. Website www.stikestms.ic.id. Email stikes.tms@gmail.com atau tmspmb7@gmail.com.
That video officiates our event today. Now, before we start, let me introduce to you today's conference agenda. First, we start with the registration session for an hour from 8 o'clock. Next is the opening conference with the national anthem of Indonesia Raya. Third is the delivery of speech from the director of the institute, followed by the opening speech from the director. Next is the delivery of short presentations from the 4 distinguished speakers, Professor Celeste Aure, Nurse Nuraini, Nurse Pawiliyah, and Sir Tito Abordo, followed by Q&A session, and lastly, closing and announcement. Ladies and gentlemen, as we begin our next session, let us hear the national anthem of Indonesia. We may now sit. Thank you for taking the time to listen to the national anthem. Distinguished guests, without further ado, we would like to invite the director of the Tri Mandiri Sakti Institute of Health Sciences Bengkulu, Bapak Dr. Andes Haji S. Effendi MS, to deliver his welcoming speech.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, greeting to us all together. The Honorable Prof. Yuliansa, as the Chairman of the Higher Education Service Institute Region 2 Palembang, although representative. The Honorable Speaker, Sir John Tito Abordo, as the Senior Emergency Department Staff Nurse at King's College Hospital and HS Foundation Trust, Denmark Hill, London. Professor Kalista Aure di Makulangan, BN, MSc, PhD, from the Department of Nursing of the Philippine Women University. Nurse Nuraini Agustini, BN, MSc, PhD, from the School of Nursing, Faculty of Health Science, Syarif Hidayatullah State, Islamic, Indonesia, Jakarta. And Nurse Pawiliyah, S.Kep, Man, as the Dean of Nursing Program of the Tri Mandiri Sakti Institute of Health Sciences, Bengkulu, Indonesia. Also to invited guests and international conference participants wherever you are today. First of all, I would like to express my gratitude to Chairman of LL-Dikti Region 2 Palembang for trusting us to help an international conference at the end of. Also goes to all speakers who have been willing to share their knowledge, and to all participants who joined the conference today. Welcome. To give you a little background about why the urgency of conducting this event all began from the very vision of STIKES Tri Mandiri Sakti Bengkulu. Our vision as an institution is to becoming a professional health institution and being an excellent in terms of disaster management, either at the national or the international level by 2033. This vision is highly relevant to us who live under the condition of Bengkulu. Bengkulu is geographically located on three tectonic plates, namely Indo-Australia, Eurasia, and Pacific. This makes Bengkulu an area that is prone to natural disaster, among many other, earthquakes, tsunami, landslide, and volcanoes. It is theoretically and dangerous place to live, but people who grow up on this land should make a living hour of it. Thus, the option is to build a association. which are not only our, but capable and have the competency to handle such disaster that could happen anytime. This can become possible by putting effort to ensure competent health workers are born and developed on this land. A good disaster management, as it is termed, might be of help to the current and future needs of Indonesia, region alike, and the rest of the world. Despite the urgency from the geographical condition, we are called today to discuss is because of our responsibility to take charge in managing the COVID-19 pandemic as a disaster too. With this, we are directing the topic today discussion on effort response in the COVID-19 disaster. And hopefully, today we can exchange idea with our common problem in the field of health and disaster management. Once again, I think and highly appreciate all parties who have made this event possible. With any luck, hopefully, what we are doing today may be of use to the wider community among us and also to the world. We, our local first said, if there is a broken needle, don't keep it in a grave. If we say something wrong, don't miss the hard work. Let us forget about our past mistakes and move forward to make peace to in and everyone. Let's start this event with Bismillahirrahmanirrahim. Wassalamualaikum warahmatullahi wabarakatuh. Enjoy discussion.
Thank you, Bapak Dr. Andes Haji SFND MS. What an energizing, welcoming speech. Ladies and gentlemen, that is the opening session. Before we proceed to the main session, let's have a 5-minute break. Thank you. Ladies and gentlemen, we are now entering the main session. First of all, I would like to introduce our first moderator, Bapak Nurse Ade Herman Surya Direja, S.Kep, man, who will assist the discussion from the first delivery of the presentation from the speaker. Bapak Ade is a registered nurse in Indonesia and a master's degree holder in the field of nursing, as well as an active lecturer at the Mandiri Sakti Institute of Health Sciences, Bengkulu. He is a fellow bachelor graduate from the University of General Ahmad Yani, Bandung, completed further studies at the Philippine Women's University, Manila, and has joined the faculty since 2011. Besides being an active lecturer, Bapak Ade sits as the head of Quality Assurance Unit, LPM, of the Mandiri Sakti Institute of Health Sciences, Bengkulu. He is also a founder of Generasi Al-Kafi Indonesia Foundation, a founder of Generasi Al-Kafi Islamic Boarding School, an active member of the National Nursing Association Bengkulu Region, a member of the National Nursing Association Commissariat of the Mandiri Sakti Institute of Health Sciences Bengkulu. He's published, among many journals, a textbook on the psychiatric nursing care with more than hundreds of copies sold nationwide. Ladies and gentlemen, please join me in welcoming Bapak Ade Herman Suryadireja.
Thank you very much, Bapak Adnan. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Ladies and gentlemen, it is an honor for me to be a moderator for the first speaker. So before we starting this conference, I would like to introduce the speaker. Actually, she was my lecturer before when I studied in the Philippines when I got master degree in nursing. Celeste Aure di Makulangan studied for a bachelor's degree in 1977 with a bachelor's of BSN Phil Women's University. Then she continued her master's education with a master of MA in nursing, fields of specialization administration and management in Phil Women's University in 1996. After that, she continued her doctoral studies with the Doctor of Education field of specialization educational management in Philippine Women's University 2007. She has a lot of professional experiences. She registered as a membership in professional in Philippine Nurses Association, International Nursing Foundation of Japan, Phil Chapter, Gerontology Nursing Association of the Philippines, ADCOA, Asia Training Center on Aging, Member Emergency Room Nurses Associations of the Philippines. Some of her publications include Student Clinical Instructions, Influence of the Nursing, Student Clinical Performance, 2018. Compendium of Researches of the Graduate School of Nursing, 2006 until 2011. RLE Handbook School of Nursing, 2013. Thesis Defense Chair and Final Member for MEN and EDD students in 2007 to present. She also got awards, citations, recognition. There are tribute to excellence, 35 years services. For the invaluable contribution and commendable services to PWU, February 2019. CAVA Award for Community Work, June 4, 1995. Certificate of recognition for having chosen as the scholar of the International Nursing Foundation of Japan and the Philippine Nurses Association, February 23, 1994. Certificate of recognition for continuous commitment in upgrading and upholding the Phil-Womanian spirit in the community, September 1992 to September 1993. Certificate of recognition for academic excellence in the orientation course for nurses of the Philippines Air Force General Hospital, July 1984. Then she would like to deliver her topic about Philippine experiences to responses in COVID-19 disaster. As we know that the case of COVID in Indonesia and also in the world is still high case. There are 280 million until now as per day, December 27. And also in Indonesia, the case is already 4,261,000. And the case death is already 144. And that is the thing that we have to discuss about how the Philippine experiences to respond in COVID-19 disaster. So please welcome Ma'am Celeste Aure di Makulangan.
Good morning. I will present the response in the COVID-19 disaster the Philippine experienced. I quote, "With loyalty, I will endeavor to aid the physician in his work and devote myself to the welfare of those committed to my care," unquote, from the Florence Nightingale Ledge. There is no best and appropriate time than this pandemic that we see with our own eyes the crucial and paramount roles that nurses play. In this fourth International Nursing Conference, all of you will learn from the guest speakers not only the roles, but the different concerns, problems, issues, challenges, and out-of-the-box solutions that nurses undertook just to meet the needs of the patients, to render the best nursing care given the situation, and for them to survive, because just like their patients, they are vulnerable to contract the disease. In this connection, my objectives for the next 30 minutes or so are the following. First, the timeline from March 12, 2020 to the present concerning pandemic situation in the Philippines. Enumerate the issues, concerns, and problems of Filipino nurses while taking care of COVID-19 patients. And lastly, the recommendations and solutions given the issues, concerns, and problems. On March 11, 2020, WHO Director General Ghebreyesus declared the novel coronavirus outbreak a global pandemic. The basis was that the number of cases outside China at that time increased 13-fold, and further increases are expected. During the first 2 weeks of March, there were over 1,000 new cases, and the highest being on March 5 to 11, with 1,828 cases nationwide. Based on the proclamation of WHO and the increasing number of cases, President Duterte declared that the 12 million or more people living in Metro Manila would not be allowed in and out of the country's economic and political center by land, local air, and sea travel from midnight of March 15 until April 14, 2020, as the region is placed under enhanced community quarantine or ECQ or total lockdown. This is a measure taken to mitigate the spread of disease from one community to another. This further means that all the schools were shut down, but the students were still required to fulfill their academic requirements. Also, and judicial branches of government were suspended, but they have to observe skeletal workforce to ensure continuous delivery of services to public. Flexible work arrangement. No more gatherings, even the holding of religious masses in the church and mosques. Business offices were closed, as well as the malls, restaurants, fast food centers, movie theaters. On the first week of April, President Duterte announced that he will lengthen the Luzon ECQ up to May 15, 2020. The second week of April, there were 2,301 cases, the highest in NCR for the month of April. As the number of confined patients increases, the Department of Labor and Employment announced that nurses and other healthcare workers will not be allowed to leave the Philippines to work in another country. because their services are needed at home. As you will notice, the number of cases in NCR continues to escalate with 3,028 cases in the National Capital Region. The last 2 weeks of May, Metro Manila, including Laguna and Cebu City in the Visayas, were under modified ECQ or MECQ. This refers to the transition phase between ECQ and General Community Quarantine or GCQ, when temporary measures are relaxed and become less necessary. This also means that a strict home quarantine will be observed. Those people who are below 20 years old and those who are 60 years old and above, pregnant women, and those with comorbidities and immune deficiency have to remain in their residence at all times. The country's capital region has been under general community quarantine for nearly half a year since June 1, except for the 2-week return to a stricter, modified, enhanced community quarantine in August, when the Philippines hit the peak in cases at over 6,000 new infections logged in a day. GCQ is a form of quarantine with moderate and lenient measures as compared to ECQ and MECQ. It is implemented in cities or provinces that have moderate to low risk of COVID-19. Safety protocols are still to be enforced in establishments and still to follow curfew hours. Metro Manila was under GCQ for the first quarter of 2021. In February, vaccination of frontliners started when the national government received 2,379,200 doses of COVID-19 vaccines in the form of Pfizer, Moderna, and later the Sinovac. However, in April, the NCR plants, that is the Metro Manila and provinces of Bulacan, Cavite, Laguna, and Rizal, were under ECQ due to a surge in COVID-19 cases. Please take note that the second week has 58,703 cases, the highest for the month of April. As time passes by, Greater Manila was under GCQ with high level and additional restrictions from July 30 to August 5, 2021. The Interagency Task Force on Emerging Infectious Disease, or the IATF-EID, mandated that all travelers, regardless of vaccination status, they must be checked for coronavirus. From August 6 to September 2021, Greater Manila was under ECQ due to rising cases of SARS-CoV-2 Delta variant, which was first detected in India. Cases nationwide was up to 125,673 cases from September 9 to 15. With the implementation of ECQ, the situation in Metro Manila improved and placed under MECQ. COVID-19 a new system of quarantine category that applies to entire cities, municipalities, and regions. It is made up of 5 alert levels and granular lockdown technique, which is a 2-week micro-level quarantine for regions declared critical zones by local government units. NCR was placed under level 3 until October 31, 2021. On November 2021, the Philippines registered 2,303 new COVID cases, the lowest single day in 8 months. The curfew hours in NCR was lifted for the first time since the COVID-19 outbreak. On November 4, the IATF approved the de-escalation of NCR from alert level 3 to alert level 2. This means that all ages allowed to move around subject to LGU rules. On November 22, 2021, the implementation of alert level system throughout the country started to control the people's movement in the midst of the pandemic. On the same date, the booster dose started, with the frontliners as the first priority. On November 30, 2021, 425 new cases nationwide were reported, the lowest since December. For the whole month of December, President Duterte announced that the whole country will be under alert level 2. Limited face-to-face classes in the chosen schools and universities nationwide was started on December 6. And on December 15, the Department of Health announced that there are 2 Omicron variants in the Philippines, and they were placed under quarantine. All the countries in the world and its people were caught flat-footed on this pandemic situation. Nobody was prepared on their contingency plan. Both the developed and the developing countries have zero knowledge about severe acute respiratory syndrome, coronavirus 2, or the SARS-CoV-2. That it is not surprising that there are issues, concerns, problems, conflicts, and even confusions as to how the government and the people will manage in controlling the spread of the virus. I will tackle the issues, concerns, problems of Filipino nurses and other healthcare workers since we're attending the 4th International Nursing Conference. I have enumerated 4 issues based on what happened since the lockdown began in March 2020. The first one is about the material resources. The lack of critical care devices, such as the ICU bedside monitors, the ICU beds and ventilators, and drugs and other medications necessary to take care of the patient. There were lack of personal protective equipment, or the PPEs. It was calculated that at least 12 PPEs per patient per day is required from emergency room to admission. At least 168 PPEs for 14 days, and additional 10 PPEs will be needed if the patient will require a surgical procedure. Because of lack of PPEs, some nurses have to forgo meals and bathroom breaks to save on it. What about ICU rooms and COVID-19 wards? Not all hospitals have an ICU. This is due to the level of training needed for health workers serving the units. only 75 or half of the 150 hospitals in Metro Manila have ICUs, and this becomes a problem since 2020. ICU occupancy means that 60% occupied, it means it is still in safe zone. 60% to 70% occupancy, moderate zone. 70% to 85% high risk zone, and 85% and above, it is in a critical zone. From July to August, the ICU reaches 79% occupancy when it faced a deadly surge in cases. And in August to September 2021, a surge of Delta variant, wherein the ICU occupancy was in moderate to high level. The second issue is about the overworked nurses and other frontliners. Since there was a surge of cases in 2020 and 2021, the nurses and doctors were overworked because they were working for more than 8 hours. Due to understaffing, they were taking care of 15 to 20 patients, leaving them exhausted, depressed, burned out, overwhelmed, and unable. There were reports of death of nurses and doctors directly taking care of COVID patients. A couple of months after President Duterte declared lockdown, the DOH announced there were 2,480 health workers who have tested positive, leaving the death toll at 31. The third issue is about underpaid nurses and unreceived benefits. Based on the Public Act 11494, or the Bayanihan to Recover as One Act, which was signed and issued in September of 2020, states that benefits for public and private health workers in the country includes special risk allowance, or SRA, not exceeding 5,000 per month. The second is life insurance. And the third is free accommodation. And lastly, meal and transportation allowance. Pending approval of monthly salary of nurses working in both public and private hospitals, in which they will receive 33,575 pesos per month, or $670. There were reports that in some private hospitals, nurses receive 10,000 to 12,000 pesos per month, or 206 to 210 US dollars per month. Because they are overworked and they have unreceived benefits and pending approval of their monthly salary, according to the Private Hospital Association of the Philippines, an estimated 40% of the private hospital nurses resigned since the start of the pandemic. Because of the unreceived benefits, nurses and doctors are out on the streets to protest and call for Department of Health Secretary Duque to resign. These are the nurses from NCR, and some came from the provinces. The fourth issue is about pandemic-induced mental health challenges. Because of increasing number of patients, Nurses witnessed the death of patients, which affected them emotionally. They experience exceptional stress because they are overworked in taking care of many patients beyond the regular 8 hours of work. Because of understaffing, they experience extreme overwork and overload. Difficult decisions to make regarding the personal and family situations and the condition in workplace. They fear of becoming infected and because of long exposure to the patients, and fear of spreading infection to families and communities. In every problems, concerns, and issues, there are always solutions to make. On material resources, especially personal protective equipment or PPEs, both public and private hospitals use crisis capacity strategies. The first strategy is about the extended use or limited use of PPEs without removing for up to 6 hours when caring for a cohort of COVID-19 patients. But this is both a solution and a problem, especially for those frontliners who have other physical conditions. The second strategy is about reprocessing or reuse process to decontaminate using disinfection or sterilization methods. Donations from private groups and individuals is one of the solutions in which Filipinos come together and do brainstorming on how they will be able to donate not only PPEs, especially masks, but also foods and drinks, especially to those frontliners who are working for more than 8 hours. Nurses are very well known to be flexible, innovative, and creative, and they do improvise a lot. Other healthcare workers like this one, who is a radiology technologist in one of the hospitals in the south of the Philippines, he used expired X-ray film and PVC as his face shield. Can you imagine that? And these two nurses, they use raincoats to use as PPEs. And these two, they use the garbage bags to be their PPEs. The other, of course, solution are the supplies coming from the government, which most of the time are lacking. The second one is about the intensive care unit occupancy and quarantine centers. So what were the solutions or the recommendations given? The hospital added beds in the emergency room for the patient to stay so that they would be able to wait for other patients who will be discharged from the ward or ICU. In this hospital, they allowed the patient to stay in the emergency room for a longer time, and they allowed one seater for them to stay with the patient. In this one, this is a church in one of the hospitals in the provinces, and the priest allowed the hospital to use their space for them to confine and treat the patients. Now, for the government who directed the hospital to use and extend the number of COVID beds. This is based on Administrative Order number 2020-16, wherein public hospitals are directed to allocate 30% of its total bed capacity, while private hospitals should allot 20%. In this model, this is an ideal 12-bed module. There should be an anteroom and a washroom in every 12-bed capacity. For mild cases, on overworked nurses and other frontliners, the government asks for volunteers, like those who are about to graduate in nursing and in medicines, and some other midwives who are working already, and other interested people who can help in contact tracing. Nurses from military hospitals were assigned to some government hospitals to augment the number of nurses. Also, government provided free transportation to and from the hospital where nurses and doctors are working, and provided private rooms in a hotel near the hospital for the nurses to stay after their tour of duty. Mental health counseling is always available, especially provided by the hospital where the nurses are working. For the underpaid nurses, President Duterte asked the nurses for patience as the government tries to come up with the money, and the budget department told the Senate it had already released 311 million pesos to pay for the special risk allowance, or the SRA, of over 20,000 health workers. This was on top of the 7 billion pesos worth of SRAs that DOH said it had obligated from December 2020 to June 2021 for over 370,000 health workers. For the last issue, which is the pandemic-induced mental health challenges, the solutions where there are mental health support teams consists of psychologists, doctors, nurses. They talk to nurses and doctors who are directly working with the patients on a scheduled day and time, or anytime they want to talk to them. Webinars on mental health are always available. Family and peer support, especially when the healthcare workers are on duty. The family text them, or during break time, they do video call. And definitely the healthcare workers are always happy to see their children during video call. Another solution was a positive thinking through prayers. In any religious affiliation, people believe that prayer is like a miracle. And in the situation where the world is in, people are praying for a miracle to happen. For some updates, employment ban reimposed by POEA on June 1, 2021. The Department of Labor and Employment Secretary Silvestro Bello III clarified that since the deployment of 6,500 health workers had been reached, the POEA announced the temporary suspension of deployment. Special risk allowance. As of September 29, 2021, the Department of Budget and Management reported it has released an additional 451.32 million pesos for 499,116 health workers This is from December 20, 2020 to June 30, 2021. In terms of new cases and deaths, as of December 3, 2021, there were 549 new cases confirmed nationwide and 235 deaths. On December 23, 2021, there were 246 new cases confirmed nationwide and 122 deaths. For the past 30 minutes or so, I have given you the timeline from March 12, 2020 to the present concerning pandemic situation in the Philippines. And I have enumerated the issues, concerns, and problems of Filipino nurses while taking care of COVID-19 patients, as well as the recommendations and solutions given the issues, concerns, and problems.
Okay.
And these are my references.
All right. All right. I was thinking that finished already with the topic Philippine experiences in the response COVID-19 disaster. Thank you very much, Ma'am Celeste Aure di Makulangan. Then, if I think the participant would like to asking or also sharing experiences, but be patient, but because we will proceed to another speaker, to the second speaker, and I will introduce the moderator of for the second speaker, Bapak Loren Joksen, S.Kep nurse, MAN. He is lecturer in undergraduate school of nursing, Sri Mandiri Sakti Institute of Health Sciences, head of research and society empowerment division, LPPM, Sri Mandiri Sakti Institute of Health Sciences, founder of Generasi Al-Kafi Indonesia Foundation, founder of Generasi Al-Kafi Islamic Boarding School, member of Indonesia Nursing Association, Bengkulu Province, member of Indonesia National Nursing Association, Commissariat of Sri Mandiri Sakti Institute of Health Sciences, Secretary of Philanthropy Institute. So, Bapak Loren, please, time is yours.
Okay, thank you very much, Sir Ade. Assalamualaikum warahmatullahi wabarakatuh. Hello, good morning, everyone. Please introduce myself. I'm Loren from Sri Mandiri Sakti Institute of Health Sciences. Today, I'm as a moderator in our international conference. I would like to introduce our honorable lecturer from Syarif Hidayatullah State Islamic, Jakarta, Indonesia. Her name is Nurse Nuraini Agustini, BN MSc, PhD, has an educational background. He studied for a bachelor degree, Bachelor of Nursing, Faculty of Nursing, University of Indonesia, years 2003. Then she continued her Master of Science in International Health Program, Kobe University, Japan, Grad School of Health Science in 2011. She also took after that, she continued her doctoral studies, PhD program, Disaster Nursing Global Leader Program, or DNGL, Graduate School of Nursing, Art and Science in University of Hyogo, 2021. She has work experience as a lecturer of mental health nursing in Nursing Diploma Islamic Village, Tangerang, 2003-2006. She also became as an internship nurse in Dharma Graha Mental Health Hospital, Tangerang, years 2005-2006. She also served as Secretary of Clinical Nursing Program, years 2011-2012, and served as Secretary School of Nursing, years 2012-2015 in Syarif Hidayatullah State Islamic, Jakarta, Indonesia, and she also served as Lecturer of Mental Health Nursing in Syarif Hidayatullah State Islamic, Jakarta, Indonesia in 2006. She conducts research and publication about current situation and supporting employment of Indonesian nursing or certified care worker candidates based on economic partnership agreement between Indonesia and Japan, and research about collaboration facilitation of mental health of disaster responders, research outreach 2021. She also became speaker on seminars since 2012 until now. She also department in Indonesia Mental Health Association years 2012 until 2016. She also served as General Secretary in Center for Development and Disaster Mental Health Nursing Service or CDDMN in 2012-2014. And she also served as President in Center for Development and Disaster Mental Health Nursing Service CDMN in 2014-2016. This is a curriculum vitae for our honorable lecturer. Please welcome Ma'am Eni Nuraini Agustin, PN, MSc, PhD. The time is yours, Ma'am.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. So it is a very good opportunity for me to share about the mental health emergency in facing COVID-19 disaster. But first of all, I would like to express my gratitude to the director and the dean of Mandiri Sakti Institute of Health Sciences Bengkulu for inviting me in this great opportunity, and also to all the distinguished speakers. I just want to say hello, and then to all the participants today. Thank you very much for attending until the second session. Excuse me, may I share screen from my own PPT?
Yes, please, Ma'am.
Okay, would you mind to allow me to share the screen?
Yeah, just a moment, Ma'am. Okay, Ma'am, please.
Still disabled? Maybe I have to wait.
Oh, still disabled, Ma'am?
Yes.
We are going to do co-host first.
Thank you. Sorry for the inconvenience matter. So let's just start our presentation today. So today I'm going to talk about mental health emergency and facing COVID-19 disasters. So based on my specialty in mental health nursing. So what I'm going to talk today is first I will, of course, I have to talk about what is mental health, and the second is what is mental health problems during pandemic in globals, and then what are the mental health problems during pandemic in Indonesia, and then what are the developed strategies to overcome the mental health problems. So First, we already know people all over the world are facing severe impact of COVID-19 pandemic on the mental and psychosocial well-being, and it results to the mental health emergency. And then the COVID-19 pandemic has brought so many changes of our habit and routines that have had occur and impact to the all aspect, and it resulted many psychological or mental distress. Several studies I found show high rates of depression and anxiety due to the COVID-19 pandemic, particularly among women, young people, those with pre-existing mental health conditions, or people, we call it ODGJ, people with mental illness, and then health workers and person living in vulnerable condition. So when we talk about mental illness, mental distress or psychological distress, we first have to recognize what is mental health. So it's very difficult to distinguish vividly about mental health. So mental health, once we call somebody have a good mental health, it means that somebody who be able to cope well with the many stressors of life. So even though they endure so many burden in their life, people who can cope well with their stressor is people who really good have a mental well-being, and also people who can realize their own potential, their own weakness, their own strengths is part of the indicator of mental health. And then people who can function productively and fruitfully, such as you attending the webinar, is one of indicator that you have a mental health well-being. And then participate into your community, join some activity in your community is also part of mental health indicator. So when we talk about mental health, it's not only talking about ourselves, but how we interact to other people. So this is yes, psychological distress is widespread among populations due to the immediate effect of COVID-19 or the virus, coronavirus on our health. Due to the consequences of measure, governments should take extremely measure to prevent the spread of coronavirus. One of the extremes measure is physical isolations. Some of people cannot be able to endure the physical isolation, especially people who being COVID-19 survivor. Their physical conditions in the lower point, and then at the same time, they cannot be able to be reached by their own family member or their social support. It makes people getting more and more stressed. And then what others, the psychological or mental distress, uncertainty. Due to the uncertainty when will this pandemic will be over, it makes some of people, many population tends to be distressed. And then COVID-19 pandemics is really taking many death toll. So many populations difficult to endure the grieving process, especially Islamic religions. In our religion, we have religious activity and practice in funeral ceremony, but people who died due to COVID-19 cannot be funeral properly due to our religion. So it makes more difficult for the family member to pass the grieving process normally. And then because of COVID-19, so hospital also and then health institution needs to do the strict procedure to accept the patient. So it makes more difficult to access the social support and health facility. Moreover, the frontline worker as well as the COVID-19 patients have to endure the experience stigmatizations because they are afraid for being or contagious or spreading the virus. And for the pre-existing people with pre-existing mental disorder people, they tend to become stressed during the COVID-19. WHO state that it's okay to not be okay. It's okay to show your psychological distress, your mental distress during this pandemic. It's a normal reaction. But for some people, if they don't receive any psychosocial support, their condition can getting worse and drop into the mental health emergency or crisis. So what is mental health emergency and crisis? It's a situation which a person's actions or behavior can lead them to hurt themselves or put them into the risks for being unable to care their own self, or they cannot function normally in the community in a healthy manner. So it's one of mental health emergency. So before the pandemic, WHO showed the projections of mental disorders or mental distress after disaster or emergency situation. So before emergency situation, of 1,000 population, only 2 up to 3% population can show severe disorders such as psychosis, schizophrenia, or psychotic. And then only 10% show mild and moderate mental disorder. But after disaster, after an emergency situation, according to WHO, only 3 up to 4% will show severe disorder, mental disorders such as psychotic, such as schizophrenia, hallucinations, delusion, or waham, we call it in Indonesia. And then while the 50 and 20% will show mild or moderate mental disorders such as anxiety, PTSD, only 15 on 20%. And then large percentage people have psychological resilience. They don't show any psychological distress or mental disorder. But this is the WHO projection before the COVID-19 pandemic or outbreak. So let's see what happens when the COVID-19 pandemic outbreak. So this is mental health problem during the pandemic. In the global record, I cite from the one meta-analysis study in 2020 among the general population globally of the 31 study in total 5,000, more than 5,000 respondents. 47% respondents show anxiety. So this anxiety arises from psychological feeling of fear, because you are fear of getting infection. You are fear that you are going to transmitting the virus. It makes many populations show the anxiety. And then there are other various psychological reactions in pandemic outbreak, such as depressions. 45% of population show depression. And then while 60.5% of population show sleeping disturbance. Because what? Because they are overthinking. They are wondering, because they're facing the uncertainty. When will this pandemic will be over? This kind of negative emotions occurred on the general population globally. It seems it's more than WHO projection. And then how about for the health worker or frontliner? For us, nurse, doctors, midwife, or pharmacists, and everyone who work at health occupations, One of meta-analysis study showed that 50.4% health workers show depressions, and then 70.5% show distress psychology such as lack of concentration, fatigue, and then loss of excitement, and then feeling guilty, and then 44.6% show anxiety, and then while 34% of health workers show insomnia in all over the world. So how about people who confirm COVID-19? They also have in the biggest risk of mental health or mental disorders. The vulnerability will be increased by 1.5 up to 2%. And also most of the confirmed COVID-19 people show decreased mental health status and PTSD, memory impairments, and most of them show agitations. Agitation is something that you cannot still on. You feel worry, you feel overwhelming, fatigue, confusion, sleep disorder, anxiety disorder, and depression. Those are the various of psychological response that commonly arise among the confirmed COVID-19 people. So how about in Indonesia? I will show you the Indonesia graphic in July 14th. In July 14th, it was written that during COVID-19 case in Indonesia have finally reached its peak on July 14th with an additional more than 50,000 cases in a single day. This is indicate a second wave of positive COVID-19 in Indonesia. I just want you to recall your memories when in the beginning July up to August was the worst, the second wave of COVID-19. At that moment, many people was confirmed with COVID-19. The health facility were collapsed, and then many dead people due to COVID-19 cannot access the health facilities. They have to die at their home because they cannot get proper medical or treatment care. And then how about the mental health problems? I just want to compare between international data and Indonesia data. So in international data among the global, only 39.9% population show anxiety. But according to the Perhimpunan Dokter Spesialis Kedokteran Jiwa website or Indonesia Psychiatric Associations, mentions that more than 65% in Indonesian population show anxiety, and then 62% depressions, and 75% show psychological trauma due to the pandemic outbreaks. This is a self-questionnaire of more than 4,000 participants in April 2020. And then most of the participants are late adolescents to the young adult, and then more than 16 years old group population also participate in this study. So government also show this result, and another study in Indonesia in 2020, what factors contribute the stress of health workers in the COVID-19 outbreak. So one study in Indonesia among 236 health workers showed that have to wear PPE every day, it's one of stressor. And then heard new cases in the media, it's one of stressor because they have to overwork, and then felt no adequate PPE. As you already know, in the beginning of pandemic outbreaks, the hazmat, the number of hazmat was limited. So same like Philippine, the health professional had to wear raincoat, plastic raincoat, because we lack of hazmat. And then another stressor is they're being afraid of transmitting the virus to their family or friends. And then also they have a conflict between carrying out the task and then maintaining personal safety. There's several factors that show that I highlighted in this study. Another study, again, according to Indonesia Psychiatrists Associations, surprisingly, for more than 4,000 participants, 1 in 5 youth has suicidal thought. And then what I really afraid of, 50% of respondents has suicidal thought almost every day. They have a strong desire to kill themselves, to end their life every day. And then 20% has suicidal thought several times a week. So this is several news showed that the COVID-19 bring the mental health emergency. I just show in English, but actually many news about suicidal attempt among the COVID-19 survivors. So what are the strategies developed for mental health? WHO and in collaboration with the Interagency Standing Committee recommend mental health psychosocial support, or MHPSS program for all over the world. So these guidelines recommend that if you want to every nation should adapt psychological first aid for the COVID-19 context, and then using comprehensive and clinical mental health psychosocial support program in humanitarian setting. And then please put more attention to the children, adults, and family during the COVID-19 response. And then consider also put more effort to the elderly or the adult. And then please pay attention to using substance abuse and then addictive behavior during the COVID-19 outbreak. So what is mental health and psychosocial support? Is any type of local or outside support that try to protect or to promote our psychosocial well-being and to prevent mental disorder or mental health or mental emergency. Why psychosocial intervention is important in pandemic COVID-19? Because the pandemic COVID-19 result loss of work, loss of the loved one, loss of opportunity together with a family. That kind of loss for some people be it hard to recover and need support. The psychosocial support can provide a support to make us stay connected, to make us feel more resilient, to bounce back, getting more stronger in mental stage. And however, in Indonesia, this is the situation in Indonesia. I have to admit that of to 34 provinces, only 28 mental health hospitals exist. So there are several provinces which not have any mental health hospital. And then in Indonesia, only 1,000 psychiatrists, more than 3,000 clinical psychologists, and then 7,000 community mental health nurses available in Indonesia, to serve more than 270 million population in Indonesia. It means one psychiatrist needs to serve 250,000 population. It doesn't make any sense. It's impossible to ask help only from mental health professional. It requires community involvement, volunteer to do the mental health activity. And then up to 445 general hospital, only 269 general hospital has mental health service or polypsychiatry. And then of more than 9,000 public health center of Puskesmas, only 42.3% Puskesmas provide community mental health service. It's a really, really hard job for Indonesia. Therefore, we adopt the pyramid of mental health psychosocial intervention. This kind of this pyramid this pyramid is layering. It means that only small amount population needs to be treated by mental health professionals, specialized mental health professional. The majority of populations only need support from family, mutual support from family and community. In this part, we work, Indonesia government try to focus on this part only because we realize we lack of resources. So who need psychosocial support? Of course, survivor, people who at risk, health workers, family, community, and should be taught during this pandemic. And then what are strategies from Indonesia government? First, we provide direct mental health care to COVID-19 survivor at quarantine house or institutions. We provide mental health counseling. Also, we provide mental health counseling as well to the health workers. And then we provide promotive and preventive actions such as psychoeducation, webinar, training of trainers, and so on. And also the Indonesia government collaboration with mental health professional associations such as Psychiatrics Association, Mental Health Nurses Associations, and Clinical Psychologists Association try to deploy, try to train many volunteers to deliver mental health psychological support. And also we switch the consultation into the teleconsultation or telemedicine. So in order to provide community-based mental health psychological support, government needs to work and collaborate with mass media to campaign about to raise the mental awareness, with company to help to promote the mental health issue with other health professional association and the community. So psychoeducation is information about COVID-19. What we learn, what we do at the psychoeducation, we provide information about COVID-19, what are the common emotional reactions and how to overcome once you get stressed. Okay, so this is our government issues several resources books about mental health strategies or how to overcome the mental distress among community, children and family, and health worker as well. And then also we provide telemedicine in collaboration with mental health professionals such as this part, mental health nursing associations provide telemedicine. This part is Ministry of Health in collaboration with Indonesia Psychiatrics Association. And this part, Sejiwa, Layanan Sejiwa or Sehat Jiwa in collaboration with clinical psychologists. Especially for the mental health, Indonesia mental health nurses, our Mental Health Nurse Association provide trainer of MHPSS. So what is the TOT consists of? It's psychoeducations. We provide basic psychoeducation skills, how to overcome stress. We teach community, we teach the volunteer how to do simple relaxation skills such as deep breathing technique, progressive relaxation muscle, and also guidance imagines. One trainer provides psychoeducation into two families. They require to assess what are the psychological reactions during the COVID-19. In order, what we done is one aim. We want to rise, we want to promote collective resilience. The principle of psychosocial support that we taught to volunteer that our psychosocial support is not a psychotherapy. They're not allowed to do psychotherapy. They're not allowed to do formal mental health evaluation or diagnosis. They are not allowed to do individual psychological debriefing. They're not allowed the long-term trauma therapies. Why? They're not allowed to do that because they are just a community member. They're not mental health professional. This kind of activity should be delivered by a certified mental health professional. So this is what we have done. Sorry for the international participant I saw in Indonesia. So the Indonesia mental health nurse has been trained more than 8,000 health workers and then more than 3,000 community and religious leaders about the psychoeducation of mental health profession, psychosocial support. And the conclusion is the pandemic COVID-19. Of course, we never expected that it's gonna happen, this kind of pandemic. It brought not only physical consequences, but also psychological emergency. And then since Indonesia is a developing country, we still lack of so many mental health resources. So building human resource capacity to deliver mental health and social care is essential. It's more important than spending money to focus on curative actions or medication action. And then community involvement is important to help developing the collective resilience. I think that's all my presentations. Thank you very much. I'm sorry if I'm too a little bit fast when I'm speaking. Thank you.
Okay, thank you very much, Ma'am. Okay, thank you very much, Ma'am Nuraini Agustini, for your presentation today. We still have two speakers to go, Ma'am Annie. So we have a question and answer section, but later. So we hope you can stay in this room. Hello, Ma'am Annie. Do you hear me? Can you hear me, Ma'am?
Yes, I can hear your voice clearly. Thank you. I will say it soon.
Okay, thank you very much, Ma'am Nuraini Agustini, for the presentations. Okay, we would like to surrender to the next moderator. We would like to introduce herself. Her name is Yulita Elvira Silviani. She is a lecturer of midwifery in STIKES, Tri Mandiri Sakti Institute of Health Sciences, Bengkulu Province. She has an educational background, studied for a bachelor's degree in Tri Mandiri Sakti Institute of Health Sciences. Then she continued her Master of Public Health, specialization Health Reproductive in University of Respati, Indonesia, Jakarta. She also served as person in charge of the Institute for Research and Community Service. She also active in professional organization and served as public relations section of the Indonesian Midwife Association, branch STIKES, Tri Mandiri Sakti Institute of Health Sciences. Please welcome, Ma'am Yulita Elvira Silviani. Time is yours.
Okay, thank you very much, Mr. Loren. Ladies and gentlemen, I'm Yulita Elvira Silviani, the moderator of this session. I'm very pleased to see you here and welcome all of you to this conference. Ladies and gentlemen, our speaker today is Mr. Pawiliyah S.Kep. Pawiliyah, as educational background, studied for a bachelor degree of STIKES Mandiri Sakti, Bengkulu. Then she continued her Master of Nursing Philippine at Women University. She has work experience as a lecturer of nursing program and served as Dean of Nursing Program of STIKES Mandiri Sakti, Bengkulu. She also became manager in Madani Center, Bengkulu, and also manager in Clinic Almina Sakti, Bengkulu. She also active in organization. She served a deputy head of the Education and Training Division of the DPW PPNI Bengkulu, Team International Journal of Nonlinear Analysis and Application DPP PPNI, and head of Regional 5 APNI Organization and Public Relations Division. Now, allow me to welcome the speaker today, Mrs. Pawiliyah. Please, Mrs. Pawiliyah, deliver his presentation, and Mrs. Pawiliyah, time is yours.
Okay, thank you, Miss Vivi. The first of all, I want to say thank you to everyone involved in this activity, and also for Higher Education Service Institution, or LL-Dikti, who has provided support for his activity. And of course, for all speakers today, Ma'am Eni, Ma'am Celeste, already here for share for the COVID-19. Okay, today I will talk about the management of pregnant women in COVID-19 pandemic. Next. Okay, let's see the picture here. So how to understanding COVID-19? We can see in that picture that single-stranded RNA viruses that have a livid, imploded, standard with the club Savit projection. And after that, COVID-19 virus bind to the ACE2 receptor to enter the cell. So then after that, an infection there. Next. Next. Okay. How does COVID-19 affect us? A coronavirus disease, 2019 COVID-19 is a pandemic caused by severe acute respiratory syndrome. And coronavirus 2 also called SARS-CoV-2, despite the widespread awareness regarding COVID-19. Many are still unaware about how it affects this human body. So let me show you the little bit about how the journey of the SARS-CoV-2. SARS-CoV-2 start in the nose or mouth or eyes and travel down to the alveoli in the lungs. As we know that alveoli suck of air where gas exchange occur. So let's see there in the picture that there is healthy and infected, moderate and severe of the alveoli. And when we see in the healthy alveoli, there is no anything there. So will normal gas exchange. And then in infected alveoli, we will see that SARS-CoV-2 structure there. And then she will enclose RNA, and after that, then as infected there. And in the moderate infected, we can see the fluid there. So disease will be disrupt the gas exchange. So in this situation, my patient will be So the manifestation like fiber, cup, and pneumonia develop, and also shortness of birth. So in the severe infection, this is all of the alveolus. There is fluid. So this is makes alveolus collapse, yeah, due to loss of the surfactant. As we know that surfactant is a very important thing for the gas exchange. So in this situation, patient need go to intensive care unit. Next. So how about the pregnant women? Actually, in the pregnant women, in normal pregnant women, there is respiratory change in pregnancy and potential COVID impact. We can see in the table about the arterial blood gas measurement in a normal pregnant in the first trimester and third trimester. There is the difference of the pH, PaO2, and PaO2 serum. So that in normally pregnant, they will get the respiratory change. So that this is a potential for COVID impact. Next. Okay, COVID-19 and pregnancy key points. Pregnant women not more susceptible to COVID-19 infection. Most affected by COVID-19 make full recovery, and 50 up to 20% develop a moderate and severe illness. Most common presentation of COVID-19 in pregnancy is fever up to 37.8 degrees Celsius and also cough. And comorbidity increase the risk of severe illness is hypertension, PET, BME, asthma, immunosuppression. And there is 2 cases COVID-19 induced coagulopathy in pregnancy, 2 cases COVID-19 induced cardiopathy in pregnancy. So severe ill patient with pneumonia. 2 cases of maternal death attributed to ARDS. If COVID-19 plus patient does deteriorate typically day 7 up to 9 after symptom. Next. Okay, COVID-19 admission and surveillance for maternal early obstetrical warning score. And this is the warning score how we will admissions surveillance. The first is for respiratory rate. Normal value is 10 up to 20 breath per minute. And for yellow orange, 21 up to 30 breath per minute. And red alert, less than 10 or more than 30 breath per minute. For oxygen saturation, 96% up to 100%. And for red orange, less than 95%. Temperature in the normal value is 36.0 up to 37.4 degrees Celsius. And for yellow orange, 35 up to 36 or 37.5 up to 38 degrees Celsius. And red orange, less than 35 or more than 38 degrees Celsius. Cytologic blood pressure, 100 up to 139, and in yellow alert, 150 up to 180 or 90 up to 100. In red is about 180 or less than 90. So diastolic blood pressure for a normal value 50 up to 89, and for yellow orange is for about 90 up to 100, and for red orange more than 100. So there is, we can see the admission and surveillance, how to maternal early obstetrical warning score. So we can early warning for the mother during pregnancy. Next. COVID-19 and antenatal management rule for thromboprophylaxis. This is a very dangerous situation in women during the pregnancy who get the thromboprophylaxis. Any pregnant patient admitted to hospital for any indication is at risk for the venous thromboprophylaxis. And also in COVID hypercoagulate state and give population use of anasaparin decreased mortality in patient with COVID severe illness. Recommended PTA prophylaxis for pregnant patient admitted with moderate to severe disease COVID. Duration depend on clinical scenario. So for moderate disease and delivery by in patient with elevated BMI. Duration based on Agent recommendation. So we have to call Agent recommendation first before we are give the prophylaxis. And then rule for cholesterol, corticosteroid guide for pregnant during COVID-19 pandemic. Corticosteroid use is an important part of prematurity treatment because it provided benefit to the fetus. Corticosteroid use may be related with the increased morbidity and mortality in novel coronavirus disease. Therefore, during the COVID-19 pandemic, an alternation in current corticosteroid practice is necessary to unequally weigh the maternal risk and fetal benefit. Next. And also for non-corticosteroid use was suggested towards COVID illness. There is insufficient specific evidence at this time to wrongly avoid in SAD in patient with COVID-19. ESA for abnormal placentas. Review the renal parameter like this NCR, and if no evidence of environmentally likely continue risk PTA more than risk of empires suspending ESA anti-recovery will likely not have a dramatic effect on PTA or IgG risk. And for indomitation for tocolysis, we given that no one tocolytic has provided benefit over another. May consider alternative choice, use clinical judgment. And SID for postpartum pain management may consider alternative choice. Next. Key point for every symptom in routine antenatal pension. All patients admitted to antenatal unit are screened at entry and daily G-shift with vital. Any patient could develop COVID symptom and infection. If a COVID screening negative patient develop temperature more than 37.80 degrees Celsius, more common symptom in pregnancy or any other symptom, give 500 fluid bolus takes 30 minutes and repeat temperature 30 minutes after bolus complete. If still more than 37.8 degrees Celsius or any other symptom, so that we have to swab for COVID-19, initial droplet contact precaution, and other investigation as appropriate based on symptomology, comorbidity. And we also have to increase maternal surveillance to vital sign with O2 saturation. Next. For COVID-19 and intrapartum management key point, regardless of GA and disease severity, recommended to hospital birth. Regardless of GA, GE, PM, based on case report of fetal compromise in women with COVID-19 diagnosis, of mild symptom maternal fetal sign, and if a moderate symptom, maternal fetal sign, and wholly fluid status to avoid fluid overload, effect ventilation work of breathing. No hydrotherapy in labor birth because this is risk of virus infection. Encourage epidural anesthesia, minimize risk of for GA. No evidence of virus in vaginal secretion, ammoniotic fluid. Use fetal scalp electrode and scalp lactate sampling as per Agjunct indication. No use of nitrous acid for pain management because this will potential aerosolization. No indicated for unless to improve maternal resuscitation effort. Emergence for Agjunct indication not because of COVID diagnosis. Allopated should not be delayed based on COVID diagnosis unless need for maternal stabilization. COVID diagnosis is not an indication for diagnosis of COVID. It's not a reason to delay an indication urgent unless need for maternal stabilization. Consideration maternal section or increasing hypoxia may use assisted vaginal birth to shorten the second step. Next. A key point for the fiber in labor is temperature more than 7.8 degrees Celsius. So we have to give it 500 cc fluid bolus. Do not give it Tylenol during that time. And after that, repeat temperature 30 minutes after bolus complete. Next. Next. Okay, this is the current list of procedures that are not according to the provincial infection disease advisory committee. The first is collection of nasopharyngeal or throat swab, ventilator circuit disconnect, chest compression, chest tube removal or insertion, and coughing extracted sputum, oral suctioning, oral hygiene, and gastroscopy or colonoscopy, laparoscopy, and then after that, endoscopy, cardiac stress test. Next. So about the aerosol gathering medical procedure. Endotracheal intubation, including during cardiopulmonary resuscitation. Cardiopulmonary resuscitation during airway management is manual ventilation, open airway suctioning, bronchoscopy diagnosis or therapeutic, and then do the autopsy, sputum indication diagnosis of therapeutic. Next. And how about the stem cell collection? Actually, in Indonesia, we for regulation, stem cell in Indonesia have been made, but not yet freely used. Only some hospital will use the stem cell like RSCM, but for another hospital, still from government still do the research for the stem cell. So that's why it is not free use for another hospital. Next. Having a baby after COVID infection, in the current state, the first is we have to do the screening at the hospital entry and screening with maternal temp in obstetrics, labor, triage, any screening negative pension. No special precaution for labor and delivery unless dictated by screening. Use universal precaution with the delivery. OB provider, surgical mask, head, eye protection, gloves, and gown, shoe cover. Anesthesia, surgical, using the surgical mask, eyes protection, glove, gown, and require intubation. For the nursing, surgical mask, use head, eyes protection, and glove, and gown, and shoe covers. Baby will not have unswept. Mother and father will not mask when having contact with a baby, skin to skin. So this is during a baby after the COVID infection. Next. Okay, how about the vaccination? Actually, in Indonesia in 2021, based on circular vaccine for pregnant and screening adjustment in the implementation of a COVID-19 vaccination, there are conditions that pregnant women may receive the COVID-19 vaccine. The first is body temperature. Pregnant women who want to be vaccinated have their body temperature below 37.5 degrees Celsius. And after that, for blood pressure, the pressure of pregnant women should be below 140/90. If the result is above 140/90, then repeat the measurement with an interval of at least 10 minutes. If it is still high, it should be postponed. And for gestational age, not all pregnant women can simply vaccine. The minimum gestational age is in the second trimester, or about 30 weeks. And there are no signs of preeclampsia because the preeclampsia is a very dangerous situation. Sure, and after that, check the preeclampsia. Next. And then there is no history of severe allergies. Pregnant women who have a history of severe allergies should also postpone their vaccine schedule. And pregnant women with comorbid like diabetes mellitus, asthma, lung disease, hyperthyroid, chronic kidney disease, or liver disease must be under control, and there are not acute complications. pregnant women with autoimmune disease. Pregnant women who suffer from autoimmune or are undergoing treatment such as lupus must also be under controlled condition and there are no acute complications. And also for women who have a blood transfusion are also not allowed to undergo vaccination until the treatment period is over. And also for the positive COVID-19, this is a penally pregnant woman also cannot be vaccinated. Okay. Yeah. Okay, thank you. That's all my presentation.
Okay, thank you very much, Ms. Pawiliyah, for giving us such information and interest presentation about pregnant women. The next moderator panel section is Ms. Vicky Febrigiana, S.Kep nurse MNS. She is a lecturer in the nursing program of Mandiri Sakti Health and Science Institute. She took her bachelor degree in Sriwijaya University and continued her master degree in family and community nursing in Kasetsart University, Thailand. She is an active lecturer and have some publication in international and national journal, and also served as reviewer and editor in Journal of Indonesian Nursing Association. Please, Ms. Vicky Febriana, this time is yours.
Okay, thank you so much, Mrs. Yulita Elvira. So here I am Vicky Febrigiana. I will be the moderator for our last but not least presenter. I would like to introduce our fourth speaker. He is Tito Abordo. He has the educational background. He took his bachelor degree from De La Salle Health Science Institute, Philippines. And then he continued Master of Arts in Nursing major in Nursing Administration, the Philippine Women University. And he also took some course, like mentorship course in the University of Surrey, United Kingdom, and emergency practice course in the Kingston and St. George University of London. And currently he is studying in the postgraduate Master in International Health in the University of the Philippines. It's an open university. And for her worker background, he served as a nurses, as active nurses, start from June 2009 as a registered nurse, staff nurse in the Makati Medical Center, Philippines, and then as a flight nurse, medical operation coordinator in the International SOS Philippines, and also active as a instructor and nursing educator. He started his career in the United Kingdom in June 2017 as a junior charge nurse in the Accident and Emergency Royal Surrey County Hospital in Egerton, Guildford, Surrey, United Kingdom. And currently, he is a senior staff nurse in the Emergency Department, King College Hospital, and HS Foundation Trust. And in this section, Mr. Tito Abordo will explain about his experience in the staff as a nursing during the COVID-19 pandemic and how the action of the pandemic in the King College Hospital. So this is the video from Mr. Tito Abordo.
So going back to my presentation, sorry about that. For the wearing of PPE, we categorized our areas as a traffic. type system. So we go from the green, amber, and red areas. There may be differences in the PPEs in each, but face mask is the standard PPE in all hospital premises, clinical or non-clinical. So starting from the green areas, so like what I said, face mask is the standard PPE in all hospital premises. These are just some of the photos of the face masks that we used. So starting with the green areas where patient has had a negative COVID test, PPE is, this is also the standard, for all kinds of patient care. So whenever we deliver routine care, we use this. So masks and eye shields maybe worn all the time or change accordingly. And this is aprons and gloves are changed every patient cares. So basically it's goggles or visor for eye protection, fluid resistant surgical mask, gloves, and apron. For the amber areas wherein people are suspected COVID or awaiting their results, and also for all standard patient care, we use the same actually. So it's goggles or visors for eye protection, fluid resistant surgical mask or gloves, surgical mask, gloves, and apron. For the red areas wherein we have confirmed COVID or in all standard patient care, we use the same one as well. So goggles, visor for eye protection, fluid resistant surgical mask, or FFP, or like the N95 mask. It's up to you depending on your risk assessment, and gloves and apron. However, it only differs with when you're undergoing or when you're delivering aerosol generating procedures such as AGP, which includes tracheal intubation or extravasal dental care or dental drilling, NAV or non-invasive ventilation such as BiPAP and CPAP, high flow oxygenation such as Optiflow, sputum induction, and respiratory tract suctioning or deep suctioning. So basically, we're going to try to initiate deep suction or any secretions that are expected from a patient deep into the lungs. We try to first don on the full PPE, just like in the photo, and try to separate them from another area in A&E, or put them in another cubicle or in a separate negative pressure area, negative pressure room wherein they're going to be isolated in their closed doors. So for testing, there's been a lot of changes with regards to the testing since the pandemic began. So it started when people with symptoms are the only ones being tested, to having self-test kits from the government and from the hospital. How many times you get tested, how many times does the patient get tested when they go to the ward. The main thing is you won't know if you had COVID if you don't get tested. So you might as well get tested or self-test as often as possible or as directed for you to be able to know if you are infected with COVID or not. So you won't transmit the infection. So in all hospital settings, all patients that are admitted and will be tested prior to having a room or ward allocation. And this is very challenging since it's talk about the capacity in the emergency department. So imagine if you got 100 people there and 50 people needs to be admitted. So 50 people needs to be tested. 50 people needs to be, the results of their testing or test would be waited. So it doesn't really come up in a very, very fast, like in minutes. So you need to wait like 2 to 3 hours, right? So however, we try our best to get the results as fast as we can. So before, the main laboratory was the one doing the testing, but recently the emergency department has its own testing laboratory already that make things faster and results are obtained faster as well. So for the room allocation, so when the patient comes to the ward, they're either COVID positive, negative, or still awaiting results. So when they are positive, they go into a COVID ward or ICU if they are unwell or intubated. Then if negative, they go into a negative COVID ward where they cohort patients. If there is a waiting for results, they go in a separate cubicles until the results are out. Also, it is very, very important for us to be anticipatory or to anticipate what the patient would need. So when a patient comes to A&E, if we think that the patient will need intubation or are we going to perform any AGPs or air generating procedures, we try to put them in a separate cubicle or in a closed cubicle so that we won't worry there after that they may transmit the infection if in case, or we would be transferring patients thereafter. Also nowadays, we were getting asymptomatic patients that comes to the ED without really respiratory symptoms or non-COVID symptoms. So sometimes they're well enough to be discharged, but sometimes we ask them to isolate, and we ask their family members to isolate as well. For the disinfection, we try to use single-use equipment or avoid use a cleaner wipe. If unsure or if the patient is COVID positive, the air gets deep cleaned from wall to wall, curtains are changed, and beds and mattresses cleaned, and before we use it again for another patient. Again, timely disinfection is very, very important, not just for the rooms. You have to coordinate with your housekeeping or with your cleaning staff. When are they going to clean the room? How are they going to be contacted? So they have to be allocated people in the air emergency department and clean the area as fast as they can, because sometimes when people come in, it's like one patient go and one patient comes in very, very fast. So it's institution based. Whatever your institution guidelines is, you can just follow it. And like what I said, coordination with housekeeping is very, very important. So for the staff support during the pandemic, a lot was affected. So I, for myself, got affected as well. So I've become very, very, I felt very burned out during the first phase of the pandemic. I found myself very depressed and sad, actually, because it's very, very overwhelming to be really in the front line of everything. So I think it is from physical and psychological stress, burnout, and overwhelmed with what is happening. So we see a lot of news about COVID, but it's very, very different when you actually see it. Hold the hand of somebody who is really, really sick or unwell and take care of them. So it's different. I cannot really describe how it feels, but it's very, very different if you're the one taking care of a patient who's having 15 liters of oxygen and still desaturating. Whatever they do, whatever they move, they would become tachypnic. They would be very, very breathless, and they would literally be short of breath and have difficulty of breathing and deteriorate. So supporting the staff is very, very important because, again, we are all humans and we also need to take care and taken care of. Staff have regular risk assessment. The staff have regular risk assessment to determine or the assessment of their safety. This includes checking their comorbidities. Are they high risk for getting COVID, or are they high risk of being exposed to COVID or to other infection? This can result from them working from home, working to another ward, or to working separately from where are they working currently. Like, for example, if they're working ICU, they're working the ED, or they're working any COVID ward. So this can again also result from them wearing a different kind of PPE. They can wear a 95 or FFP mask all the time, or they can be redeployed into a non-clinical area. Well, it depends on the institution. This was done to support the manpower in the busy areas wherein people are redeployed to other areas. So for areas wherein they've closed it because they're not functional, such as the surgical cases wherein planned surgeries are not being done, outpatient cases are not being done, or outpatient services being done during the first part of the pandemic. So those staff have been really operations of the A&E and those areas. So also working from home in the healthcare setting was limited because, unlike other jobs, caring for a patient cannot be done virtually, but some staff can work from home, and they did and opted to do so up until the moment. But they have to do risk assessment and they have to talk to their manager and management about it. So An in-house psychologist or mental health team was assigned before and during the peak of the pandemic. But all the time, the staff can phone or make an appointment or drop in at the hospital's well-being team or national support hotlines. And lastly, offering vaccines for everybody, such as the COVID vaccine and flu vaccine, is available all the time for every staff. And the managers always remind everybody to get their COVID and flu vaccine. So staff support again. So the well-being of this, there is a well-being center in the hospital. At first, during the first part of the pandemic, when everybody's not working, like other occupation is not working, they help us with in the well-being center by being there, manning it. We can talk to them, we can have their support, we can chat to them. So the unit and departmental catch up. Also, you have to have a regular meeting with your team. Can be virtually, can be socially distant, can be by email, can be by WhatsApp, or on whatever kind of communication you're in, so that they would be able to know what is happening and what are the changes. You have to have open communication with everybody so that everybody knows, again, what is happening. And they won't be afraid of expressing their concerns when it comes to the pandemic. Nourishment. So we receive a lot of food during the height of the pandemic, but you also have to make sure that everybody's hydrated and well taken care of. So the proper breaks, you have to remind them to eat, especially if they're in their full PPE. You have to remind them to hydrate and go to the bathroom as well, so that they won't be sick afterwards. And acknowledge everybody in the team. So we have to acknowledge that everybody's working well and everybody's doing their part. We also have a staff testing hub, wherein if you phone the hospital or the trust that you're sick, you can just go to the staff testing hub, and then you will be tested there. Again, also PPE is very, very important. So you have to make sure that the trust or your staff has a lot of PPE to use, because we can't do our job if we don't have PPE or we're not protected. If we got sick, that would be a problem, because all the they're the ones that takes care of the sick people. So it's very, very important for us to be protected as well. Again, communication. So this is very important as well. When I said communication, it is with the general trust or the general hospital. So in the system software that we use, so when a patient gets admitted, you can put, if a patient is being tested already or have you tested it for COVID, are they negative or are they positive, or still waiting for the result? So the site managers or the general managers in the hospital can see how many people are still waiting COVID tests, how many people are positive, how many people are negative with COVID. Hence, they can allocate an appropriate room for them, or allocate a ward for them, which is COVID positive, or what kind of ward they would be needed. Handover is very, very important as well, because this is a change of responsibility and accountability. You tell them what are the changes, you tell them how they are, you tell them how the unit is going. You also have to have a very good communication with the bed managers or the supervisors, because they're the ones that allocates the bed. So you have to tell them if the patient would need ICU, a COVID ward, a separate ward, or a cubicle, or a general negative COVID ward, and also staff involvement. So you have to involve the staff with decision making, because by the end of the day, it's who is working there that is greatly affected for all the changes. So who's on the front line or who's in the in front of the patient are the ones experiencing all the changes. So we have to have everybody involved. So from the top management to the staff, or to everybody, they have to be involved in the decision making, and they have to be involved when it comes to changes as well. And lastly, you have to support each other. So, simple hi, hello, and how are you? Medical or non-medical is very, very important, because from this you would determine if they are still okay, have they got any concern or any other concern that they would. Again, I've discussed triage, personal protective equipment, testing, room allocation, disinfection, staff support, communication, and support in general. So thank you and stay safe. And again, I really, really apologize if this is recorded setting. This is actually my first time to do a Zoom recorded webinar. But I hope you've learned something about it. Don't hesitate to try to email me about it.
Okay, thank you so much for Mr. Jan Tito. As he mentioned that actually he cannot join us now because the different time between Indonesia and London, but he is pleased to welcome the question too, and then we will send the question from you to his email directly. So now we are continue to the question and answer. We already got 3 questions for 3 speakers. Then I will read this question first. This is question for Miss Ma'am Eni Nuraini. This question is from Miss Anugrah Aprioni, a student from nursing program in STIKES Mandiri Sakti Bengkulu. Her question is, during the pandemic COVID-19, we are always feeling anxiety. Sometimes we are feeling that we are infected, but the result of PCR was found negative. So is that a somatic symptom? And how to deal with this psychosomatic symptom? Miss Annie, can you hear the question clearly?
Yes, I can hear the question clearly. Thank you very much. Should I answer now?
Yes, ma'am, you can answer now.
Okay, thank you. Thank you very much. I forgot her name. Thank you for your questions, asking about the psychosomatic symptoms that frequently occur during the pandemic outbreaks, yes, and how to prevent it. So, it is sometimes your psychosomatics or the psychological reactions occur because you too much frequently opened the news from the social media. So it is important to have social distancing to your social media because you have to stop those informations. It's quite overwhelming for you if you continue to follow up the social media. Sometimes you have make a distance to the social media first, and then the second part is if you thought that you psychosomatic, it's because you tend to focus to one thing. So it's important to do some another activity, healthy activity. If you have some hobbies, just do the hobbies. When you fully enjoy, you feel present, you enjoy your physical activity, you are practicing mindfulness. And it helps you to reduce your overthinking, and it can lead to psychosomatic. And then the last one, I think it's not the last, it should be an important thing, is going back to your religious activities, prayers and other Quran recitations. Also, it's important for you to feel surrenders what God will to us. So distractions, block or make a distance to your social media, and then getting back to your religious activity. I think it's very simple for you. That's all. Or maybe if you typical of extrovert person, you are an extrovert person's personality. So talking with friends, it's one of emotional catharsis to reduce your overthinkings and over worry. I think I hope it can help you to understand how to overcome the psychosomatic symptoms.
Okay, thank you, ma'am. Eni, I think it's really clear explanation. And then I would like to inform the participant, please do not make an absent of present in the chat box of the Zoom, because it will make the committee difficult to find the question. So please just fill the Google form attendance. So the question from another participant clearly in the chat box. Now I have a question for Ma'am Celeste di Bangkulagan. This question is from Herlina Safrizal, a nurse from Curup Hospital. The question is, as we know that Omicron is the newest type of COVID, so is there a new case of this type have been found in Philippines? Miss Ma'am di Bangkulagan, are you here?
Yes, I've heard the question. Thank you for that. Now, so far, we have 3 Omicron cases in the Philippines. The third one was reported last December 16, of second week of December, and he is an OFW, the overseas Filipino worker who came in from Qatar. However, he is asymptomatic, and the thing is, he did not receive any vaccination. So, but he was quarantined because he landed in Mactan International Airport, that is in Cebu. That is 1 hour by plane from Manila. So he was quarantined for 2 weeks, and after that he again was tested, and he tested negative. Right now he was sent home in Cavite, that is 1 hour and a half from Manila, and he is and the DOH, or the Department of Health, is still monitoring the patient, including the 2 earlier cases of Omicron. They are still under observation or monitored by the DOH. So far we have 3 Omicron cases in the Philippines. Thank you.
Okay, thank you, ma'am, for the answer and the explanation. And now we have third question. The third question is for Ma'am Pawiliyah. This question is from Devi Hartati, a student from STIKES Mandiri Sakti Bengkulu. Her question is, what if a woman gets COVID during her pregnancy? Are there any additional risks to her and her baby? Thank you, Ma'am Pawiliyah. You can answer now.
Okay, thank you for the question. And so in the clinical study, the large space from prior to data being submitted to the FDA for the emergency use authorization, all the manufacturers perform prior to the data being submitted to women who were pregnant or breastfeeding, just because there was not any data on that and everybody scary of things that will happen during pregnancy or during breastfeeding. However, during the study, some women, either the screening visit, they were enrolled in the study, or they become pregnant during the study. So there are a handful of women that did become pregnant, and some who were breastfeeding during those vaccine study. And what all the manufacturer found is no signal that there was any dangers to the fetus. So nothing unusual between the vaccine group and the placebo group in terms of the pregnancies and the pregnancy outcome. In additional to that, the manufacturers have done study in animals who were pregnant or getting pregnant and agents, giving even twice the equivalent dose. The human equivalent dose to animal did not result in any dangers that occur during pregnancy. So vaccine been tested in pregnant or breastfeeding women through that study. So I hope that you will understand my question, my answer.
Okay, thank you so much, Ma'am Pawiliyah. I think it's clear enough, and she also gave the evidence base for the question. And then we have another question for Ma'am Nuraini. This is a question from Faisal. He is a student of nursing program in STIKES Mandiri Sakti Bengkulu. And the question is, what should we do as a nursing students doing psychotherapy for the people who are infected by virus COVID-19? Ma'am Annie, you can answer. Thank you.
Okay, thank you, Muhammad something. I forget his name, but very interesting question. Thank you very much. So, you asking about the psychotherapy. I already mentioned in my my presentations that because since you are a nursing student, you are not a mental health professional, so you are not allowed to perform psychotherapy. But you still can have a chance to help and provide psychosocial support, not psychotherapy, but psychosocial support to the confirmed COVID-19 person or patients. So what kind of psychosocial support? At this period, I think you try to contact I have no idea at your school if you have lecturers specialized in mental health nursing. They usually the lecturer, the mental health nurse or lecturer. We join to Indonesia Mental Health Nurse Association, and we frequently have training of trainer to become a volunteer, providing mental health or psychosocial support. We call it DKJPS, dukungan kesehatan jiwa psikososial. The training already held since last year and will be continue until next year. So I think you still have a chance if you want to become a volunteer, and then you will receive 4 days training about psychosocial support. But meanwhile, if you still don't have any chance to join that kind of trainer of training, you still have a chance to do emotional catharsis technique, or we call it feeling ventilations atau curcol. Yeah. Just call your friends who confirm COVID-19, be there, be present, and then just do the active listening, help them to validate, because most of COVID-19 survivor, they're really afraid of being guilty. Am I wrong if I ask to the God? Am I wrong if I complain to the God why I got infected? Am I wrong if I cry every day because I come from COVID-19? Something that feeling guilty, the survivor want to express their negative emotion, but they are too afraid become a sin or make a mistake, feeling guilty. So it's your job, it's your role to help them. Just hear and validate it. It's okay to not be okay. It's okay you are feeling sad. It's okay you want to angry, you want to complain, and then questioning to the God why God give you this kind of examinations, something like that. Just a simple active listening. It's a part of psychological first aid. No need psychotherapy. Just being there, being present to your friend, and then doing active listening, it's a part of psychological first aid. You still can do that. Okay, good luck for you, and hopefully you can get any chance to have TOT, DKJPS in the future.
Okay, thank you, Ma'am Annie. I think it's really important point that as I know that Mr. Faisal is currently practice as a co-nurse in the hospital. Maybe he has experience that meet with the COVID-19, and like Ma'am Annie said, that just being there for the patient is already help the patient. And then, is there any question from the participant? And if you would like to ask directly to the speaker, it's okay. You can raise your hand on the Zoom. And for the question for Mr. Tito, we will just write the question in the Zoom chat, and then we will send the question to his email. Sudah itu tadi. Sudah ini tadi. Ini yang tadi. Okay. Mrs. Pawiliyah, by the previous question that it's already been tested and it's also proved in the journal, right?
Okay.
Okay, I think we will not proceed with the question. And then, is there anyone? I give you a chance one more. If no, then we will stop the question and answer section. Okay, I think maybe that's all for this question and answer section. And I'm as the moderator and as the representative for all the moderator, we would like to say thank you so much for the opportunity. And also we would like to say sorry if there is any mistake from us while we conduct this question and answer section. And then I will give back the ceremony to Mr. Adnan. Thank you so much.
Okay, thank you so much, Bu Fikir Febriana, S.Kep, and thank you very much, Bapak Ibu, other moderators, for leading the prior sessions, and also to the distinguished speakers for delivering such informative presentations to all of us. Ladies and gentlemen, those are the agendas we have presented to you this morning. Now we would like to take a documentation for this event to commemorate today's agenda. So we request to all participants to kindly turn on their cameras all together. Kepada bapak-bapak, ibu-ibu, kami memohon untuk mengaktifkan kameranya jika berkenan dan tidak memiliki masalah konektivitas. If you don't have any connectivity difficulties. Okay. Okay, everyone get ready. Okay, for the first out of 6 slide, smile. Okay, next, second, smile, okay, hold. Okay, next. Okay, next. Next. 1, 2, 3, smile. Okay, that's it. Okay, yeah, okay. I think we're finished. Thank you very much for taking your time with us. Ladies and gentlemen, as we have finished our keynote speech and plenary session this morning, until afternoon, coming up would be the last session, which is the parallel discussion rooms or paper presentation sessions. And we should inform you that this parallel discussion session would be open starting from 1 p.m. this afternoon until 5 p.m. for today. And then the rest of the presentations would be continued later. So technically, we have at least 1 hour to take a short break. To all participants, may we remind you, you may proceed to this breakout room link as shown in the slides at the designated time. Once again, I, Muhammad Adnan, would like to thank each and every one of you for joining today. We wish you all a very pleasant day. Happy discussing, everyone. Good luck. Goodbye.